Hi guys, good evening. Good evening. Hi guys, good evening. I hope everybody is able to see me, hear me. All right, can we all start? Hi Deep, good evening. Right, so without wasting any further time, let's kickstart today's discussion. Right. So, so today we'll be talking about the diverticular disease or the disorder of the esophagus, right? So we'll talk about the esophageal diverticulum. Now, when we talk about an esophageal diverticulum, let's understand what do you mean by this diverticulum, and then we'll decide and discuss what is the further course that we need to take in this disorder, right? We'll be discussing, hi Vicky, good evening, hi Ritu, good evening. One second, able to see the chat. Okay. So today's topic is about esophageal diverticulum. We'll be talking about all the important aspects of this. Now, when you talk about the diverticulum, the first of all you need to understand what is this word diverticulum. Now, diverticulum is basically nothing but an outpouching of a partial or complete thickness. It is an outpouching of a partial or a complete thickness of viscera through an anatomical weakness. Through an anatomical weakness. Now, this is the basic definition of a diverticulum, that it is almost like a hernia, but hernia is through a wall, but this is through a visceral anatomy, or I can say the weakness within the viscera itself, right? So, it's outpouching of a partial or complete thickness of a viscera through an anatomical weakness is what we call it as a diverticular disease. Now, as I told you, either it could be a partial thickness or it could be a complete thickness. So, based upon this, you have a true and a false diverticulum. So based upon what you can see across here, a diverticulum can be divided into two varieties. A diverticulum can be divided into two varieties. You have the true diverticulum as well as the false diverticulum. You have the true diverticulum as well as the false diverticulum. In true diverticulum, all four layers of the gut, all four layers are involved. All four layers are involved in diverticulum, that is mucosa, submucosa, inner circular, outer longitudinal, obviously the seromuscular in the serosal surface. We call it as if all four layers are involved, that is going to be true. If it is only a mucosa and the submucosa is involved, it is only the mucosa and the submucosa is involved. Now this is what we call it as a false diverticulum. This is what we call it as a false diverticulum. So we have diverticulum which can be a true or a false, and basically it's an outpouching through an weakness in the visceral anatomy per se. As simple as that. Now we say anywhere in the body, let it be esophagus, small bowel, large bowel, anywhere in the body, in order to develop diverticulum, there are three important prerequisites, right? So there are three important prerequisites for the development of diverticulum. Now, in order to develop a diverticulum, especially the acquired one, not the congenital ones, in order to develop a diverticulum, the three important prerequisites. Number one, the age of the patient must be high. Number two, there should be presence of an anatomical weakness. There has to be an anatomical weakness and some trigger factor. There has to be some trigger factor. So when I use the word trigger factor, is basically anything that results in increase in intraluminal pressure. There's increase in intraluminal pressure. So due to XYZ reasons that we can discuss as we progress through the lecture, there's certain factors which are going to increase the intraluminal pressure, and that will result in a diverticulum, as simple as that, right? So when it comes down to the esophagus, you will have the same thing obeyed in order to develop a diverticulum. So most of the diverticulum will be seen more common in elderly patients because age is important. We'll discuss the anatomical weakness as well as the trigger factor, right? So when it comes down to the esophageal diverticulum, based upon their location, we can divide them into three categories. So this is the prerequisite. So this is the minimum requirement for a diverticulum to be formed. So when it comes down to the esophagus, what are the different types of the esophageal diverticulum? So when we talk about the types of esophageal diverticulum. When it comes down to the types of the esophageal diverticulum, number one, you have the pharyngeal diverticulum, that is at the pharyngeal region. You have the pharyngeal diverticulum. Then you have the mid-esophageal diverticulum. We have the mid-esophageal diverticulum. And then you have the epiphrenic diverticulum. Then you have the epiphrenic diverticulum. So we divide the esophageal diverticulum basically or majority into three different components: the pharyngeal, the mid-esophageal, and the epiphrenic diverticulum. So when I say what is the three varieties that you need to understand, so if you look at the esophagus, this is where the cricopharynx lies, and this is where the rest of the esophagus continues across, and this is how it is going to turn. So this is the representation of the esophagus. Needless to tell you that this happens to be the diaphragm, so we'll be considering this as well. So based upon from where it is going to be presented, we have three different varieties. Again, we are using magic so that you don't need to work hard. You have all three esophagus bang 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 in the same context, right? थोड़ा सा और adjust कर लेते हैं. Okay. Now when I say the pharyngeal diverticulum, that means it is going to arise from the pharyngeal part of the esophagus, so which is going to be an outpouching at this location. If the outpouching is at this location, this is your pharyngeal. If it is in the mid region, this is your mid-esophageal. If it is going to be, as a mid-esophageal is here, I'll tell you why I'm being specific about it. And the epiphrenic is going to be above the level of diaphragm, right? So the three diverticulums which are present, if it is at the level of the neck, it is called as the pharyngeal. If it is in the mid-esophagus, it is going to be a mid-esophageal diverticulum, also called as the parabronchial one. And the epiphrenic is the one which is going to be present at the lower part of the esophagus, right? Now, the criteria for epiphrenic is from the gastroesophageal junction. So, if you take this is the gastroesophageal junction, from the gastroesophageal junction, within 10 centimeters. So, if you take this is the gastroesophageal junction, from here within 10 centimeters. This is a 10 centimeter mark. So from the gastroesophageal junction within 10 centimeters, if the diverticulum arises, this is what we call it as the epiphrenic diverticulum. So the criteria for epiphrenic is that the diverticulum should arise within the 10 centimeters of the gastroesophageal junction, right? Now, just for the sake of understanding, the first one is what we call it as the Zenker's, diverticulum. This is 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 the Zenker's, diverticul This is what we call it as the Zenker's diverticulum. This is what we call it as a parabronchial diverticulum. This is what we call it as the parabronchial diverticulum. And the last one that you have is epiphrenic, right? The epiphrenic, the criteria is within 10 centimeters, right? Now, so this is where you have the different varieties of the diverticulum that is going to be arising from. Okay. So our goal is to understand each one of them. As I've given this diagram just to understand, remember the Zenkers is usually, if you look at this is the right side, this is the left side, this is the right side, this is the left side, this is the right side, this is the left side. Zenkers is usually a left-sided diverticulum, whereas the other two are right-sided diverticulum. If you just have patience to understand this, we'll go in detail about it. But for now, Zenkers is left-sided, the other two are right-sided diverticulum. The other two are right-sided diverticulum. So our objective is to understand the Zenker's diverticulum of the esophagus, right? So our opening topic, which we'll discuss in detail now, is going to be the Zenker's diverticulum of the esophagus. It is going to be the Zenker's diverticulum of esophagus. It is the Zenker's diverticulum. This is the Zenker's diverticulum of the esophagus. Now you remember I told there are three important prerequisites for the development of the Zenker's diverticulum. Now the three important prerequisites for the development of the diverticulum: number one, the age of the patient must be high. Number two, there has to be presence of an anatomical weakness. There has to be presence of an anatomical weakness, and obviously there has to be a trigger factor. A trigger factor here increases the luminal pressure, that can be because of swallowing hard foods, right? Now that is why when we say the Zenker's diverticulum, most of the patients of the Zenker's diverticulum are elderly patients. They will present to you after the age of 50 to 60 years. So they are seen after the fifth decade of life. Now the anatomical weakness is what we have to understand, that how a patient of Zenker's diverticulum will present to us. So why would a diverticulum form? Why would a diverticulum form in the first place, right? Why would a diverticulum form in the first place? That is your anatomical weakness that you need to consider. So let's understand the anatomical weakness, right? So when you look at the anatomical weakness, just for the sake of understanding, we have done enough amount of our fair share of work when it comes down to the tracheal anatomy as well. Now, when you look at the whole concept of the tracheal anatomy that we have already ran through, now let's say this happens to be the hyoid bone. This happens to be the thyroid cartilage. This happens to be the cricoid cartilage. And this happens to be the trachea. Right? So these are your tracheal rings which are present. These are the tracheal rings which are present across it, right? Now you have these membranes, which is nothing but the hyothyroid membrane and the thyrocricoid membrane that is present here. Now we all know the esophagus is going to be running behind this. So let's say this is the esophageal lumen that is running across it. So as I told you, there is no serosa here. The outermost layer that you can associate in the esophagus is going to be the longitudinal muscle of the esophagus, and this is where you have the longitudinal muscle. There's small variation in the longitudinal muscles also, but for now you remember this is the longitudinal muscles, right? Now, there are two sets of muscles which are going to be running from these ones. Number one is going to be a set of muscle which is running obliquely like this, and another set of muscle which is going to be running transversely like this, right? So you see, this is the muscle that we're talking about, right? The first set of muscle that you can see here is the obliquely placed thyropharyngeus. You see, these are the obliquely placed thyropharyngeus muscle which is encircling the esophagus here. Obviously these are your superior constrictors, or I can say these are the one which are also going to form the upper esophageal sphincter. That is how you can see, we remembered in our anatomical orientation also. So look at this, this happens to be the hyoid bone, and these are the muscles. These are the muscles which are running from behind, right? So you can see this is the first set of muscle, which is your oblique thyropharyngeus, and then you see these are this transverse cricopharyngeus muscles, which are also present here. You can see these are the two sets of muscles which are present here. Now you can see the two sets of muscles. One is your oblique thyropharyngeus, another one is your transverse cricopharyngeus muscle. This is a transverse cricopharyngeus muscle, and these two set of muscles is now leaving a small area or a triangular area which is not covered by this muscle, and this triangular area which is left behind. This triangular area which is left behind is what we call it as the Killian's dehiscence. Now this is what we call it as a Killian's dehiscence. Again, a very important concept that you need to understand. The Killian's dehiscence is present on the posterior surface of the esophagus. Now this is an anatomical weakness that is present here. Another interesting thing that you will notice here, that this longitudinal muscle which is ejecting here, inside this you have the circular muscle of the esophagus, right? So these longitudinal muscles also arch off. So from this point you see even the longitudinal muscles which are present here, they usually arch, exposing the inner part, and the inner part is your circular muscles of the esophagus, right? So this area is actually exposing the circular muscles of the esophagus, right? So what has happened is there are two sets of muscles which are present here. So the longitudinal muscles is here exposing the inner circular muscle. So again there's another triangular area which is not guarded by any muscles. There are two triangles which are going to have an anatomical weakness, the upper triangle and the lower triangle. Now this upper triangle is what we call it as the Killian's triangle. This is one anatomical weakness, and this is what we call it as the Lamieux's triangle. This is what we call it as the Lamieux's triangle. This is what we call it as the Lamieux's triangle. So the two triangular area which is going to have a weakness, one is your Killian's, another one is Lamieux's. Every time they'll ask you the same question, same orientation, wahi faltu ka sawal, same repetition. Nothing is going to change if the concept is clear. So if you look at this whole orientation, this is now attached to the this is the thyroid cartilage, right? You see these muscles are simply attaching to that of the thyroid cartilage which is here, right? Here it is attaching to cricoid cartilage. So this is your cricoid cartilage to which it is attaching to. And then you have the hyoid bone, nothing, not relevant in this discussion form, but this is how it has been running across. Okay. Now when you look at this, the whole analogy or the whole concept of it, you will understand that there are two sets of muscles which are present. This is an upper oblique. This is an upper oblique muscle. Now this upper oblique muscle is your thyropharyngeus. This is your thyropharyngeus. And this is your lower transverse. This is your lower transverse, which is cricopharyngeus. This is your cricopharyngeus muscle. So there are two sets of muscles. I'm just going to take the triangular denotions out from here so that we can understand better. The two muscles which are present, the upper, which is an oblique muscle, which is your thyropharyngeus, and the transverse one, which is cricopharyngeus. This is your hyoid bone, this is your thyroid cartilage, this is your cricoid cartilage. So you always have a doubt ki which is upper, which is lower. But a thyroid cartilage will be up, no, cricoid cartilage is low. So thyropharyngeus upar aayega, cricopharyngeus niche aayega. Ab see, look at the thyroid cartilage ka orientation, it itself is like this, you know, like an angulated. You can see these angles. So obviously it is transverse. Sorry, it is going to be your oblique, whereas cricopharyngeus is going to be flat, which is going to be your transverse, right? But in two muscular components that you have, this is what we call it as the Killian's triangle. This is what we call it as the Killian's triangle, and this is what we call it as the Lamier's triangle. This is what we call it as the Lamier's triangle. The Killian's triangle is also called as the Killian-Jamieson's triangle. Bus as a synonyms hai. Agar if you really want to know, it is also called as a Killian-Jamieson triangle. Also called as the Killian-Jamieson triangle, right? So our second prerequisite is going to be the anatomical weakness, which is also now being clicked off, right? So there are two anatomical weaknesses that is there. Number one is going to be the Killian's triangle. Number two, it is going to be the Lamier's triangle. Out of these, what is going to happen once the anatomical weakness kicks off? You can see that the esophageal diverticulum can actually pop out from here. It can actually pop out from here. So if it pops out from here, if the diverticulum pops out from here, this is what we call it as the Zenker's diverticulum. So if the diverticulum pops out, if the diverticulum pops out through these areas, this will be called as the Zenker's diverticulum. This will be called as the Zenker's diverticulum. This will be called as a Zenker's diverticulum. So that's the basic orientation that you need to have with respect to your diverticular disorder. Clear? Okay. Now, to make your life difficult, exactly what are the three different diverticular components that you can see? So just keep this in picture and we'll replicate this again. We'll do a quick replication that you have. You have the hyoid bone, you have the thyroid cartilage, then you have the cricoid cartilage. This happens to be the trachea. This happens to be the trachea that we already have. Correct? Okay. Now behind this we know that we have the esophagus. We're saying behind this you have the esophagus, and this is the esophagus that you have, right? Nothing spectacular about it. We have just learned all this, so this is going to be persistent across here. Now I told that there is going to be, so this is, let's say, the tracheal lumen, this is the esophageal lumen that you have. Now we have two sets of muscles which we have already committed to that. Number one is going to be your thyropharyngeus, which is here. And number two, we have the cricopharyngeus muscle, which we are committing it to here. There is one set of muscle here. There is another set of muscle which is going to be present here. You see, these are the muscular sets that you have, right? We already know there are two triangular weaknesses that we have, which we have to commit to it. So here, this is going to be the longitudinal muscle, which is here, and you'll see the inner circular muscles which are going to be exposed here. These are your inner circular muscles which are going to be present, right? Now, the diverticulum can arise when you see comprehensively. So if I enclose this off, this is how the cricopharyngeus and the thyropharyngeus muscles orientation is, right? Now, The diverticulum can arise from the midline or from the lateral wall. If it arises from that of the midline, this is your Zenkus. It can arise from the lateral wall also, and it can arise from the Lamius triangle also. So there are three potential sites of arising the diverticulum from, right? So one that is going to be arising right dead in the midline, which is going to occur. One that arises on the lateral side, it could be the left or the right lateral side, and one that is going to arise from the Lamius triangle. So there are three potential sites of the diverticulum that can be arising from across here. The one that arises dead in the center is what we call it as the Zenker's diverticulum. This is what we call it as the Zenker's diverticulum. One that arises from the Lamius triangle is obviously called as the Lamius diverticulum. Obviously called as the Lamius diverticulum. Now one that arises from the lateral side, not in the dead in the center, this is what we call it as the Killian-Jamieson's diverticulum. It's a Killian-Jamieson's diverticulum. Now, if I have to be more precise about the Killian-Jamieson's diverticulum, it is going to arise from the lateral aspect. A small correction here. I'm just going to okay. Right. A small correction that you have in the Killian-Jamieson's is you will notice that this circular muscles is going to be in the lower end also. So the diverticulum that actually outpouches is from the lower end, which is here. So from the Killian's triangle, it is going to be Zenker's only, but it is going to be from the Lamius lower edge, right? That is below the cricopharyngeus muscle. You see this. This is going to be our Killian-Jamieson's diverticulum. This is what we call as the Killian-Jamieson's diverticulum. Okay. Small correction. So you now know the three diverticulums that can arise from here. The Zenker's can arise, the Lamius can arise, or the Killian-Jamieson's diverticulum. All these three can arise from this particular side. Just for the sake of understanding, this is your oblique thyropharyngeus. This is your transverse cricopharyngeus, right? That's your oblique thyropharyngeus. This is your transverse cricopharyngeus muscle. Between these muscles, there is an outpouching, and those outpouchings are what we call it as diverticulum. The three diverticulums that are possible from the Killian's triangle, if it is going to arise, this is what we call it as our Killian's triangle. This would be our Zenker's. If it arises from the Lamius triangle on the lateral side, it is going to be the Killian-Jamieson's. If it is going to be from the midline, it is going to be your Lamius diverticulum. It is going to be Lamius diverticulum. Many a times, even a lot of residents, when they join general surgery and they start working up these diverticular disorders, they also fail to understand this composite, right? So there's a very, very decent concept that you need to build up, that three diverticulums from the cervical region can arise, but it is also important to understand that not all three of them are important. Only the Zenker's is what we have to concentrate on. So far, so good. So we have concluded the anatomical weakness also. When it comes down to the trigger factor, any trigger factor which can contribute to increase in intraluminal pressure, increase in intraluminal pressure, anything that can contribute to increase in intraluminal pressure will result in diverticulum or Zenker's diverticulum per se, right? Now, coming back to the clinical presentation, how will they land up to you? So I've seen fair share of Zenker's diverticulum. We'll talk about the clinical presentation of Zenker's diverticulum. So we all know when you talk about the Zenker's diverticulum, we're talking about an outpouching in the upper part of the esophagus, which is going to be here. which is the presentation. So we all are worried about this, right? So we're talking about this disorder which is going to be present, right? So this is a disorder that we all are worried about, and we will be learning that if a patient lands up to us, how would this patient present to us? As simple as that. Now, before we move down, remember just to classify the Zenker's diverticulum. Number one, Zenker's diverticulum is an acquired diverticulum. That means obviously it is formed after birth. It is not formed during birth. Number two, it is an example of a false diverticulum. That means it will not have all the four layers of the gut, only the mucosa and the submucosa will be participating. And more importantly, it is more common on the left side because our Killian's triangle is also more prone to form on the left side. So the defect when you talk about in or the weakness that we talk about in the Zenker's diverticulum is what we call it as the Killian's triangle. We have already given you the Killian's triangle is formed by the thyropharyngeus, cricopharyngeus junctions. So two muscles which are forming them to form a Killian's triangle. Now Killian's triangle is present on the posterior or the posterolateral side. It is going to be present on the posterolateral surfaces. So that is why the Zenker's diverticulum will also be more common on the left-sided posterolateral. It is going to be left-sided posterolateral. So how does these patients land up to us in the clinic? So when you talk about the clinical presentation, many a times you will notice that these are the patients who will have other symptoms rather than the primary diverticulum because there are no such diverticular symptoms per se. We'll try to understand that. So I saw this patient, like I've seen multiple of them, and one of these patients who walked up to my clinic was a 70-year-old gentleman. Okay. You need to understand that these guys are pretty old, so by the time they come to the clinic, it is already late. Because obviously they are dependent on their kids who are already working. They come back from their office and then they bring him to the hospital or the clinic. It usually gets late. So this one fine gentleman who walked up to our hospital at around evening 8:39 was waiting for an OPD consultation. We usually don't have an evening consultation after 6. Now, it so happened that I finished my OT and I was about to leave, and obviously my nursing staff came and told, sir, there's a patient who's been waiting. And I refused politely by saying कि देखो late हो गया है, मैं भी थक गया हूँ, मैं आपको कल देखूंगा. So this gentleman was like, नहीं sir, I've come from a very, very long place and I've heard you are, the best in town, so I wanted to get checked. Now, देखो, I would have refused, but he told I'm best in town. अब जब acknowledge कर रहा है best in town, तो अच्छा नहीं लगता ना to avoid him. So I said, okay, fine, now because you're saying so good things about me, I'll go have a look at it. But then I told him, we'll make it very quick. And his immediate answer was, doc, you got it. In fact, I will tell you my problem in a very, very jovial fashion. I said, sir, I'm not in that mood. Just tell me your problem, we'll be done with it. He said, no, sir, you will understand. I said, oh, great. I asked him a question, sir, what is your problem? And he says, sir, rather than telling my problem, I would like to show you a magic. And I said, sir, I'm in no mood of watching a magic. He said, no, sir, I insist. Dekho, ek magic dikhaunga. I said, no, sir, rehne do. He said, no, sir, you have to watch it. I said, okay, what? He said, sir, yesterday I ate chicken. Today I ate potato. I will take out the chicken and show it to you. And I'm like, this is nonsense. Yes, I know you're also thinking, but you need to understand that the first line of the clinical features or his symptoms itself has given away the diagnosis. He's saying that there is regurgitation. There is regurgitation of previous day food particle. There is regurgitation of previous day food particle. See, we all have regurgitation. You will have it, I'll have it, but we don't have something that we ate yesterday. How is this guy having a regurgitation of previous day food particle? It so happens that every time he is going to eat, let's say yesterday he ate chicken. Now the chicken is going puck, 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 and some amount of chicken goes into diverticulum and says puck, puck, and gets accumulated. Now this rest of the chicken has gone into the tummy. Today he decided I will eat garam garam aloo. The aloo goes in. Okay. The aloo goes in. Aloo says okay, okay. He wants to enter the diverticulum. There is no space for the aloo, so aloo goes forward. Now, when he has a regurgitation, what is going to happen? He is going to regurgitate whatever is present in the diverticulum. And in the diverticulum, what do you have? You have chicken. So, you see, this is what he will be regurgitating. So, chicken comes out, right? Looks like, World Cup's trophy. But who loves chicken will see everything in that way. Okay? So he takes chicken out, and that's how you have the regurgitation of previous day food particle. And I'm like, okay, great, but I don't want you to talk. I'm not able to take any longer. In fact, talking to him is going to suffocate me. It irritates me. What is happening? He says, as he continues to talk, no, all that chicken that was there in the diverticulum also puri raat reh ke sad gaya tha na. So what is going to happen? It is going to ferment, and that fermentation is going to give you a bad smell, and that bad smell is what we call it as halitosis. Now, what is this halitosis? Halitosis is a persistent, it is persistent bad breath. See, for you and me, we all experience a bad breath. But all I do, drink a water, sip something, brush your teeth, and it's gone. This guy, on the other hand, no matter what he does, even if he drinks an entire bottle of scent, I'm going to assure you that this persistent bad breath will be there. Hence, it is called as halitosis. The research in a previous day food particle, there is halitosis. Along with that, he says, sir, I also have something called as intermittent. I have intermittent dysphagia. Now, I've heard about dysphagia, which is progressive, non-progressive. Hi Allah, what is this intermittent? Now, intermittent basically means on and off, on and off. Why it is happening on and off? What is going to happen is, as the diverticulum is going to get loaded, this loaded diverticulum is now going to become bigger. जैसे जैसे खाना भरेगा तो ये डायवर्टिकुलम मोटा हो जाएगा ना, और जैसे डायवर्टिकुलम मोटा हो जाएगा तो ऑब्वियसली पीछे से कंप्रेस करेगा. यू नीड टू अंडरस्टैंड दैट दी posterior surface ये वर्टिब्रा है, तो डायवर्टिकुलम वर्टिब्रा को थोड़ा ना पुश करेगा. कॉमन सेंस की बात है भाई. अरे वर्टिब्रा इज सो स्ट्रांग, व्हाटएवर गेट लॉस्ट. तो डायवर्टिकुलम में जब खाना भरेगा तो डायवर्टिकुलम मोटा तो बनेगा. जब मोटा बनेगा तो वो क्या करेगा? इट इज नाउ गोइंग टू बज आउट. सो यू विल सी द डायवर्टिकुलम ट्राइज टू एक्सपैंड. Because it tries to expand, there is no posterior surface. It is now going to compress anteriorly. तो जो भी खाना था, whatever the food was there, it has now gone into the diverticulum. The diverticulum has expanded. अब diverticulum expand होगा तो obviously true lumen पे pressure डाल रहा है ना. The true lumen of the diverticulum is here. If you fail to understand, बेटा, true lumen of the diverticulum is this. ये true lumen है. जो green green दिखा रहे हैं हम true lumen है. तो आप देखो ट्रू ल्यूमन का तो बैंड बजा हुआ है. क्यों बैंड बजा है? क्योंकि डायवर्टिकुलम ने दबा दिया है. सो इट इज बीन प्रेस्ड. सो बिकॉज इट इज बीन प्रेस्ड, यू विल नोटिस, भाई और बहनों, इट इज नाउ कंप्रेस्ड. अब बिकॉज इट इज कंप्रेस्ड बाय द डायवर्टिकुलम. ये है आउट पाउच, ये पाउच, ये पोटला जो बना हुआ है खाना भरने की वजह से, इसने डायवर्टिकुलम के ल्यूमन को दबा दिया. अगर ल्यूमन को दबा दिया तो ऑब्वियसली ल्यूमन में जगह नहीं है. ल्यूमन में जगह नहीं है तो इट इज गोइंग टू कॉज dysphagia. So patient is now experiencing hi, it is difficulty in swallowing as well. अब problem क्या है? Now you need to understand. अब देखो chicken वाला phenomena, previous day food particles अब regurgitate मारा. The minute he regurgitates, obviously the diverticulum is going to become खाली. अब खाली diverticulum में दम थोड़ी ना है. तो diverticulum हुआ खाली, तो lumen हुआ back to normal. Now when the diverticulum becomes empty, अब इसके अंदर कुछ बचा ही नहीं है, obviously the lumen is now going to expand. Dysphagia will improve. तो हर बार जब खाना खाएगा डायवर्टिकुलम में फिल करेगा, and that filling in the diverticulum is now going to cause, it is now going to compress the esophagus, resulting in dysphagia. And once the compression is relieved of, dysphagia resolves. So hence the patient is going to have this magic symptom which is called as intermittent dysphagia. So regurgitation of previous day food particles, halitosis, intermittent dysphagia, all these are going to be present. And more importantly, जब खाना निकल के आएगा तो regurgitate करते वक्त it can go into your trachea also, and if it goes into trachea, what it is going to cause? It is now going to cause aspiration. It will result in aspiration pneumonia. Now, along with aspiration pneumonia, this aspiration pneumonia will result in pulmonary symptoms. It will result in pulmonary symptoms. And if patient is a known case of diabetes that is indicating poor immunity, they can also land up with lung abscess. They can also land up with lung abscess. Okay. So there is regurgitation of previous day food particle, there is halitosis, there is intermittent dysphagia and pulmonary symptoms. These are the presenting features that you will see a patient of Zenker's diverticulum. Okay. Now, once our patient comes with these features, okay, we said let's evaluate. So I'm going to take the patient for investigation. Now, usually whenever a patient comes with dysphagia, it becomes almost like a precedent that you have to do a barium swallow. You ask the patient to drink the barium, take a radiograph, and when you do a barium swallow, you will see the barium is going to pass through the esophagus and it is going to pool into the diverticular space. So once the barium pools in, so let's say this is the barium that you have given. Let's say this is the barium that you give, the barium goes in, it is going to pull up into the pouch, and when you take the x-ray, you will only be able to see this pouch filled barium. When you take the x-ray across, in the x-ray I cannot see anything, I will be only able to see, so this pouch filled barium is going to be present across here. So this pouch filled barium, this pouch filled barium is Zenker's diverticulum. This pouch-filled barium is confirmatory that you have a patient with Zenker's diverticulum. In fact, barium swallow is also considered to be the single best investigation. So it is the investigation of choice for Zenker's diverticulum. Now, in order to plan for surgery, you can also do a CECT of the thorax and the abdomen. So another thing that I would actually add up here is going to be a contrast CT of neck and thorax. I'll do a contrast CT of neck and thorax to see the diverticular status, right? Now, once you have made a diagnosis that the patient is having a Zenker's diverticulum, you can also go ahead with upper GI endoscopy. You can do an upper GI endoscopy to visualize and confirm that what we are looking into. So you have a barium swallow, you have a CCT of the neck and thorax, and you can also go ahead with upper GI endoscopy, right? Now, when it comes down to the diagnostic criteria, this is how you're going to work it out, right? Now, how do you manage the Zenker's diverticulum? To talk about the management of Zenker's diverticulum. Management of the Zenker's diverticulum. When you look at the Zenker's diverticulum management per se, you need to understand the width of the diverticular mouth. So the width of this diverticular mouth, if it is less than 3 centimeters or more than 3 centimeters. It's a less than 3 centimeter wide mouth, or if it is more than 3 centimeter wide mouth of the Zenker's diverticulum, right? If it is less than 3 centimeters, then you have to go ahead with open repair. But if it is more than 3 centimeters, then you do something called as endoscopic Dolman surgery. You do something called as the endoscopic Dolman's surgery, right? So if it is less than 3 centimeters, you have to go with an open repair. If it is more than 3 centimeters, a wide mouth diverticulum, you can go ahead with endoscopic Dolman's repair. Now, in an open repair, we do a diverticulectomy with, I can say, a primary repair, right? So what is this is, when you look at the open repair, this is where you have the outpouching which is present. This is the outpouching that is going to be present. So I'm going to excise the diverticulum from its component. So I've done a diverticulectomy is done. So once the diverticulectomy is done, you will see that there will be a defect in the mucosal surface, right? So there's a defect in the mucosal surface that you have created, and this defect in the mucosal surface, will be done a primary repair. We'll do a primary repair, and once the objective is performed, right? So once the primary repair is done, this is how it would look like. right? This whole procedure is what we call it as diverticulectomy with primary repair. Let's do a diverticulectomy with a primary repair. This is what we call it as your open repair. In an endoscopic Dolman surgery, as you can see that this is the esophagus and this is the diverticulum. So the whole problem in the diverticulum is the food is now going to go and get stuck here. The whole problem is the food is getting stuck in this area. So what we do is we take an endo-GI stapler. I position the stapler in a manner that it is going to be in this particular fashion. You take your stapler and you position your stapler like this, right? Now we all know the stapler is going to have the pins. It is going to cut as well as it is going to seal. So I have put my endo-GI stapler into this. So my whole goal is, you see this septa which is present. You see this is dividing the true lumen from a false lumen. So if I say this happens to be a true lumen and this happens to be a false lumen. So a true lumen has been separated from the false lumen by this septa. So I've taken this endo-GI stapler, I will punch this. Now the minute I punch my endo-GI stapler, you will see that the pins which are present here is now going to fire and they'll cut through this. Now once they cut through this, the ultimate result will be like this. This will be our ultimate result and this is where the pins were fired, right? So you can see that in an endoscopic Dolman surgery, I have simply removed the septa. The septa is gone. It has now become the true lumen and the false lumen merged together to become one proper lumen. So the food, whichever is going to come, whenever the patient is going to eat, the food comes here, even it goes into the diverticulum, it is now going to slip back into the esophagus, right? So this is your endoscopic Dolman surgery that you can perform. Epiphrenic diverticulums, no, they're usually non-symptomatic. You don't need to worry about it. I'll simply talk about the mid-esophageal or the parabronchial ones. Give me a second. Aye. Now, when we talk about the mid-esophageal, it is the mid-esophageal or also called as the parabronchial. Talk about the mid-esophageal or the parabronchial diverticulum. So if you analyze this whole component of this, it is the mid-esophageal or the parabronchial diverticulum. Let's understand this. Now, if you look at the cause, it is usually after post TB, that is tubercular lymphadenitis. Now, in order to understand the whole concept of this, again the diverticulum in general can be divided into two varieties. So when you talk about diverticulum in general, they're divided into pulsion and traction. So there are two varieties of diverticulum based upon how the pathophysiology works them to form. One is a pulsion diverticulum, another one is a tractional diverticulum. Now the pulsion diverticulum is what we call it as a pushing diverticulum, and a tractional diverticulum is what we call it as a pulling diverticulum. Now in simple concept, whenever the diverticulum is formed, if the diverticulum is formed because the pressure that is increased within the lumen, so this outpouching that you can see, let's say there is an outpouching that is occurring here. Now this outpouching is because of the pressure which is increased inside the lumen. This is what we call as pushing diverticulum, somebody is pushing it. On the other hand, if the outpouching is formed because somebody is pulling it from outside, if somebody is pulling it from outside, this is what we call it as the tractional diverticulum. So pulsion is a pushing diverticulum, traction is an example of a pulling diverticulum. So diverticulum can be formed because of these two reasons. Either it has to be a push or a pull diverticulum. Now when it comes down to your mid-esophageal or parabronchial diverticulum, remember it is an example of a true diverticulum. It is an example of a true diverticulum. This is an example of a tractional diverticulum. It is an example of a tractional diverticulum. Now, in the same context, when you go to Zenker's diverticulum, Zenker's is an example of a pulsion diverticulum. It is an example of a pulsion. It is not an example of tractional, it's an example of a pulsion diverticulum. Whereas your mid-esophageal or parabronchial is an example of tractional diverticulum. This is more common on the right side for a simple fact. In the thorax, on the left you have aorta, so the aorta is now going to support the esophagus from the left side, so it won't allow anything to pop from the left, so hence it usually pops from the right side. So it's an example of a true diverticulum, it's a tractional diverticulum, and this is usually right sided. So the question is, who is applying that traction? Again, a very beautiful concept. Now imagine that this is the esophagus. Now onto the, if I just put this on this side, this is the right sided diverticulum, this is the left side of the esophagus. So right of the esophagus, left of the esophagus. Left you have the aorta. I'm just saying, left you have the aorta, so there is no space, it cannot occur. On the right you have the trachea which is running. So this is trachea which is running anteriorly as well as on the right side, right? And this is the bifurcation that you usually have. Now we have these lymph nodes which are present. I hope everybody knows it, right? So in tubercular lymphadenitis, you will see that all these lymph nodes are now going to become large. All these lymph nodes are now going to become large in TB lymphadenitis. So this is the picture of a TB lymphadenitis. Sorry guys. This is an example of TB lymphadenitis, right? Now, when a patient develops a TB lymphadenitis, obviously these lymph nodes are going to become giant large and they are now going to compress on the esophagus. So if I only isolate the esophagus, you will see that this is the lumen of the esophagus, right? And these are the TB lymphadenitis nodes. They usually they get matted also. So this is how they are present. Now what I did is I started the patient on ATT. Now these ATT is now going to hit the node. Now when they hit the node, obviously the bacteria are starting to die, the node will start to shrink. Now as the node is going to become smaller, you need to understand what is going to happen. So if this is the esophagus, right? Initially the node was this big, right? Now the node is shrinking in size, right? So initially this was the node, and the ATT the node shrink. Now as the node is shrinking, it is pulling, because it is adherent to the esophageal wall, it will pull the esophageal wall with the node. Now in the same way, you see the multiple other nodes which are coalesced, they all are shrinking in size. So you can see the impact. It is not because of one node. The multiple nodes, when all these nodes shrink, they all pull the esophageal wall towards them. Now as they pull the esophageal wall towards them, they're still adherent to the node, but this time you see the outpouching is going to occur, and that pulled out outpouching with respect to the TBC, so the nodes are still adherent, right? So this pull has now resulted in diverticulum, and this is what we call it as the mid-esophageal or the parabronchial diverticulum. So that is how you will see most of the patients with mid-esophageal or a parabronchial diverticulum develops because of this pull post ATT, and this is what is going to happen. The patient will have same features. So how do you manage it? So what we are keen is the management principles of this diverticulum. So the mid-esophageal diverticulum, will see the diverticular mouth same as Zenker's, but this time it is less than 2 centimeters or more than 2 centimeters. If it is less than 2 centimeters, we say do nothing, just observation and follow up. It is observation and follow-up. On the other hand, it is more than 2 centimeters or irrespective if there are presence of symptoms. More than 2 centimeters or irrespective of that, if the patient starts developing symptoms, this is an indication for intervention. You can do a diverticulo, you can do a diverticulopexy with the thoracic vertebral fascia. With thoracic vertebral fascia. You can do a diverticulopexy with the thoracic vertebral fascia. Now, what do you mean by this? Let's understand this as well. When I say this, you need to understand if this is the esophagus, and let's say this happens, so just for the sake of understanding, this is a mid-esophageal diverticulum. These are the vertebrae that you have. This is the vertebra that is present here. So the whole problem in a diverticulum is because the food is getting pulled out, right? That means it is getting accumulated at one side. So we say the food, when the patient is eating, it is going to get accumulated here. So what we do is, we are now going to do a diverticulopexy. So what is this diverticulopexy is? Now the whole problem is, it is a dependent area, the food is getting accumulated, change into a non-dependent area, as simple as that. How do you change that into a non-dependent area is, I am now going to pull this up. So let's say this is a prevertebral fascia, the green layer is your prevertebral fascia. What I'll do is, I will pull this diverticulum up like this. Okay. We already have the vertebra which is here. We already have a vertebra which is like here, and this is the prevertebral fascia. We anchor the diverticulum to the prevertebral fascia, right? So this is, pexy means fixation. So I'm doing a diverticulopexy to the prevertebral fascia. So this time when the patient is trying to eat the food goes in, even if it enters the diverticulum, it cannot stay, and it just passes across, right? So this is the objective. If not, another option that you have is of diverticulectomy. Excise it, remove it, throw it, right? So this is another option that you can do with respect to this, right? So this is all that you should know in the diverticular disorders of the esophagus. Okay? So now we have completed the entire Zenker's diverticulum. We know what is the basic objective, what are the different varieties of the diverticulum that you have. We also know the prerequisites that are required. Just for the sake of understanding, I'll just add here only, there's another form that we have discussed it, that the diverticulum. Another is when you talk about the diverticulum, so that your notes are completed. When you talk about the diverticulum, I said it can be of two different forms, the pulsion and the traction. Pulsion is a pushing diverticulum. Traction is a pulling diverticulum, right? So we spoke about what are the varieties, the prerequisites, different forms, where do you find them, their clinical presentation, their anatomical weaknesses that you should know in the area of Zenker's, what are the findings that you have, the clinical representation, investigation, then management, looking at the mid-esophageal parabronchial, and BAM, its management as well. So we have covered exclusively, extensively every single form that is there for the diverticular disorder. Thank you so much for joining. We'll see you next week continuing on our esophageal series. Until then, thank you. Study well, read well. Any questions, any queries, you know where to get us. Right always to the surgery guide. So if any questions, any queries that you have, just send a message here. It's the both Telegram as well as Instagram. This is by my name, that is a Dr. Sandeep. Okay. So if any questions, any queries, write us across here. Thank you so much for joining. See you next week. Goodbye. Good night. Take care. Bye bye.